the honor and pleasure to interview today Dr. Tara Graff, who is a pioneer in lymphoma research, and her presentation caught my attention at SOHO 2025, so I wanted to ask her about the details of her research. Thank you, Dr. Graff, for being with us. Let me ask you about the drug that you're developing and the context of this research, please.
Yes, so the trial looked at mosunetuzumab, which is another one of our CD20, CD3 bispecific antibodies being looked at in lymphoma. In this trial, we actually studied mosunetuzumab in its subcutaneous formulation. Right now, mosunetuzumab is commercially available in an intravenous formulation for third-line relapse refractory follicular lymphoma. So not only did we want to look at the sub-Q formulation, which was shown in a phase 2 trial to not be inferior to IV, so looking at that drug in the sub-Q formulation and then in an unmet need in frontline marginal zone lymphoma. This was done within the MorningSun trial, which was a basket trial looking at different cohorts of lymphoma, so follicular lymphoma in the frontline marginal zone, frontline DLBCL in the elderly unfit population, as well as relapse refractory mantle cell, Richter transformation, and transformed follicular lymphoma. We know there's an unmet need in marginal zone lymphoma because right now we're still using chemoimmunotherapy, and obviously just by being at SOHO, this week, we've seen that the movement is really towards a chemo-free or as chemo-free as possible environment. And that's what we did in this trial. And so step-up dosing, is so important with bispecifics to decrease that risk of CRS, which we have to be concerned about with bispecifics. And, the study design really was such to do just that. It was a great trial, and I was really excited to be able to present the data here.
So tell us about the schedule and the results in terms of efficacy.
So step-up dosing for mosunetuzumab subcutaneous is a little bit different than it is for IV. Patients receive a dose of 5 milligrams on cycle 1, day 1 of therapy, and immediately jump to the target dose of 45 milligrams on day 8 of cycle 1, followed by one more dose for day 15 of cycle 1 to complete that step-up dosing. And then they receive that 45 milligram dose on day 1 of each subsequent cycle for a total of 17 cycles.
And so the cycles are once a month?
Those are for mosunetuzumab, they're every 3 weeks. Okay. Yeah, the weeks are a little bit different depending on the bispecific. For mosunetuzumab, it's every 3 weeks. The nice thing about the sub-Q formulation, though, is it really cuts down on chair time for patients. They're not sitting in an infusion center for 4 hours after their dose being monitored. So it's a very convenient way of doing the dosing. And so it's a really nice one for the physicians. You can get more patients in. And also for the patient, just not having to sit in a chair for half their day.
And how many patients have you treated, and what were the results?
So I have treated about 5 patients for specifically in that realm. I have one patient that comes to mind that is really near and dear to my heart. She was the first patient with marginal zone lymphoma, splenic, that we enrolled in the trial. She completed her 17 cycles in September of 2023, and I just saw her Tuesday before coming here, and she remains in a complete remission. So the efficacy results of the trial were excellent. Right now, based on the trial that was the time point that was presented, it's for 18 months follow-up. There are obviously patients that have, passed that, and the median PFS was not reached, which is important to note. Majority of patients, who were responding are still responding. So the results look good. Obviously, we need more time. It's always great to see a high overall response rate, but you want to make sure that response is maintained.
So what was the overall response rate?
Close to 80%.
And so at 2 years, do you have any data on duration of response and survival?
So far, all of the patients that were studied are still alive, and I think more than 63% of patients, remain in a CR.
And this is a total of how many patients?
So there was a total of
about.
So there were 36 patients. 36 patients. Yes, 36 patients in the marginal zone cohort. I think about that for a second. I've answered that question a bunch, and I'm like, wait a minute, I had to think about that. Yeah. And if you look at the waterfall plot that I presented, you'll see a bunch of beautiful dark blue lines showing the CR. So it was so those responses were maintained. Six of the 36 patients were not able to be evaluated just based on, their baseline characteristics, the initial scans, marrows, and things that were done. So they couldn't have that, the full assessment.
And side effects of the subcutaneous compared to the IV?
So the one nice thing about the subcutaneous, so pros and cons. The one thing that we have with the subcutaneous formulation that we don't have with the IV is injection site reactions. So you have to be aware of that with any of the sub-Q formulations of any of the drugs we use, that we do see the injection site reactions. I would say overall, no one stops therapy because of them, but you just need to be watching them and paying attention to that. That's unique for the sub-Q. The one nice thing with the sub-Q is that the rates of CRS appear to be lower with the sub-Q formulation than with the IV formulation. And in this trial, in this cohort specifically, majority of the events were all grade 1 and no grade 3, grade 4 CRS events, and even more important, no signs of any ICANS or neurotoxicity.
So this looks amazing, great results. What are the plans in the future for this drug?
Well, so what I think this shows us is that we should continue studying mosunetuzumab in the sub-Q formulation. I do believe it'll get approved in frontline marginal zone lymphoma. I do think mosunetuzumab overall will probably get a sub-Q approval, which will be great because right now it's intravenous. And I think for a lot of people, they don't want to have to get another IV, sit in a chair, right? And so I think as we're seeing from SOHO, the combination now, is Moza frontline, monotherapy, and nothing marginal zone. Is it going to be paired with another drug? We're looking at all of these partners. I think it sets a precedent, though, in this cohort where we've been doing, Rituxan and chemo or Rituxan monotherapy. I think to be able to give our younger patients with marginal zone more than just a Band-Aid that holds them for a few years, I think is going to be really important. But we're going to need longer-term follow-up. So I think it's definitely moving that needle again into a chemo-free environment, and hopefully having long-term remissions in these patients with an indolent disease.
Thank you, Dr. Tara Graff, and good luck with this future research, which looks very exciting.
Thank you.